Well, good afternoon, everyone. And thank you for attending today's forum here at the Washington, D.C. Office of Mathematica Policy Research, as well as those participating on the webinar. This event is being sponsored by Mathematica's Center for Healthcare Effectiveness. And the Center for Healthcare Effectiveness conducts and disseminates research and policy analyses that support better decisions at the point of care. Our focus is on the delivery systems and policy environments that help clinicians and patients make more informed decisions, using information on outcomes and effectiveness. And there's our website. My name is Ann O'Malley. I'm a senior fellow at Mathematica and deputy director at the center. Our session today includes both an in-person and online audience, which is joining us via webcast. So to help ensure the highest possible sound quality for our participants, we ask that those of us here in the DC office please turn off all electronic devices. We are video recording today's forum, and we'll post that video on the website next week. We'll also be asking questions from the audience at the end of the forum today, so we're going to try to save those to the end. But we hope to have a lively Q&A session. For those on the webinar, please submit your questions electronically through the Q&A panel on your screen at any time during today's forum, and we will alternate your questions with those in person here. Now I'd like to introduce our distinguished panel. First we have Dr. Michael McWilliams, who will share his findings from a recent study published in JAMA Internal Medicine about the association between financial integration between hospitals and physicians and the cost of care. Dr. McWilliams is an associate professor of healthcare policy and medicine at Harvard Medical School and a practicing general internist at the Brigham and Women's Hospital. Next, Dr. James Rachofsky is a senior fellow at Mathematica, and he will provide us with an overview of what else we know about the associations between hospital and physician integration, cost, and quality. We will then hear from a panel of experts on the policy implications of hospital employment of physicians. Our panel includes Dr. Stuart Gutterman, a senior scholar at Academy Health, an expert in Medicare, payment reform, and healthcare spending. Dr. Craig Schneider, a senior fellow at Mathematica and project director of the Center for Medicare and Medicaid's Innovations Project on Learning Systems for Accountable Care Organizations. And finally, the director of the CHCE, Dr. Eugene Rich, who will discuss what research still needs to be done to better understand how financial and organizational arrangements can impact variations in medical care. So to start today's discussion, I just wanted to share with you some findings from a study we did a few years ago at the Center for Studying Health System Change, from our site visits to 12 randomly selected practices across the country. And one of the things we focused on during the site visit was the increased employment of physicians by hospitals. And so we interviewed numerous stakeholders, ranging from providers, hospitals, and physicians to employers and insurers, and safety net hospitals as well. And we heard from the hospital perspective several reasons for employing physicians. While a lot of them talked about looking towards the future and seeing that ACOs were coming down the line, their primary reason at that point in time was to increase market share and referrals for their inpatient admissions, lucrative tests and procedures by specialists, because they're still predominantly functioning under DRG and fee-for-service payment. They also felt that they would have greater leverage with health plans on prices once they were integrated with the physicians. And as I mentioned earlier, they had an eye toward the future. I mean, they know ACOs were coming at the time. Bundled payments, penalties for readmissions were just on the horizon. From the physician perspective, we heard that particularly docs who were in very consolidated hospital markets, that they really were afraid of being squeezed out of the market if they didn't become an employee of the hospital. They were very nervous that the hospital would bring in other groups and contract with outside providers. Physicians, particularly in primary care, continue to face rising overhead but flat reimbursement. So that's another reason that made employment attractive. There was high tech and the need to implement health information technology and meaningful use, which is very important, but also puts a strain on practices, especially small ones. There's always the fear of malpractice premium issues, and then work-life balance issues, particularly in newer generations of physicians who tend to particularly value that. And then back then when we did these site visits, they wanted help navigating the complex changes in the delivery system, the reporting and payment models. They heard about ACOs coming, and now we know with MACRA and MIPS and other things that's even getting more complex for physicians to navigate. So what are the opportunities and risks of hospital employment of physicians? Well, on the opportunities side, there's certainly potential economies of scale. So your orthopedic department can all order its equipment and supplies from the same company and potentially save money. Whether that gets translated into savings for patients is another question. The hospitals have influence over the physician's actions, so theoretically they can try to move a group of providers towards certain behaviors and establish a structure for better integration clinically. And it provides one-stop shopping for patients in a sense when all the providers are in the same system, work in the same electronic health record, and kind of can communicate with each other better that way. But there are certainly risks. First, we know that fee-for-service is still the predominant payment incentive, and that coordination of care under fee-for-service is not something that happens naturally. And there have been numerous studies showing that fragmentation of care is actually promoted by a fee-for-service payment. We found in some markets for this community tracking study that access can shift markedly for patients if a hospital drops a plan network, for example, the Medicaid managed care contract, and if they're the only game in town, that population is in trouble. And then there's a potential for higher costs. So with the ownership of the physician practices by the hospital systems, they now have increased leverage at the hospital systems over commercial health plans in particular on payment rates. It exacerbates pressure to increase volume of services done at the hospital and by their specialists. They also can charge facility fees for offices, even if the offices are not on their campus, but if they own them, they still get paid those facility fees. And then lastly, it presents kind of an added risk to the demise of smaller independent practices, those with 10 or fewer physicians who still represent a pretty significant chunk of both the physician and patient care market. So there are policy implications for this, and we'll talk a lot more about this later today. But the first point is that greater hospital employment of physicians does not necessarily mean clinical integration will follow. There's two completely separate issues requiring a lot of attention on the clinical side. And then secondly, there's obviously a risk raising costs without improving quality if there isn't broader payment reform that incentivizes coordination of care. So now I'd like to turn it over to Dr. McWilliams to talk to us about his new study.
Thanks very much. Really a pleasure to be here. And just did a nice job of answering or giving an answer to this question, so I won't belabor these points. I'll be referring to physician-hospital integration as vertical integration, borrowing some jargon from economics, and that saves me 3 syllables. And by integration, I really mean financial integration and more specifically ownership. So either employment of physicians in hospital-owned, hospital outpatient departments that are on campus or hospital-acquired or hospital-owned off-campus physician practices, focusing on ownership for the most part because that is what we can measure better at this point. In much of the discourse that I've heard and read about this topic, it seems to be a foregone conclusion that payment reform will stimulate a lot more provider consolidation, some going so far as to say that already the ACA and the payment reforms that it entails has set in motion a sort of tidal wave of mergers and acquisitions. But I haven't really seen any strong evidence of this, so I think this question really deserves some more careful consideration. There's certainly reasons why we might expect more integration under payment reform. The first being potential efficiencies from ownership, and Ann just covered the potential sources of those efficiencies. The one I might add is potentially lower transaction costs with an ownership structure in place. And the second reason having less to do with efficiency and more to do with strategy, so based more on sociological theory of organizational behavior, that organizations try to obtain the resources that they need in order to survive. So that may manifest under new payment models as hospitals acquiring primary care practices, for example, in order to survive and preserve market share under new payment models. But there are also reasons to question the extent to which we will see more integration in response to new payment models. As Ann alluded to, the efficiencies, the conceptual efficiencies from integration just may not pan out. It's important to note that even if a vertically integrated organization is better positioned to manage care, and that's not clear, but even if it is, what is clear is that the incentives for that organization to achieve efficiencies through care management are actually often much weaker than for independent physician groups. So if you think, for example, about a vertically integrated organization in an ACO contract, its incentives to prevent a hospitalization are much weaker than for an independent physician group because it loses the fee-for-service profits from the prevented hospitalization, whereas for the physician group, it just gets the shared savings bonus without any offsets. Another reason may be there may be economies of scale or scope, but there also may be diseconomies, for example, from the cost of managing internal politics at big organizations. And moreover, there are already reasons for integration under fee-for-service, which may then become weaker reasons under new payment models, including, for example, the incentives to boost admissions and referrals for lucrative hospital outpatient department services. I'll be referring to hospital outpatient departments as HOPDs. If bargaining power is the main motivation for integration, then we should probably see it continue unabated, whether providers are seeking greater bargaining leverage to command higher prices under fee-for-service or higher budgets under new payment models. Then perhaps we should continue to see the same amount of integration. So what I'd like to do is bring to bear some new empirical evidence on these three questions. The first, which I'll focus on most, is from this recent study of ours that Ann mentioned. The lead author, Hannah Nieprash, is a talented doctoral student in our program, did much of the heavy lifting here. So in this study, we looked at the study period 2008 through 2012. We used two sources of data, the Truven Health market scan commercial claims and the Medicare claims. We used the market scan claims to measure inpatient and outpatient spending and utilization at a patient level in the commercial sector. But the data do not contain provider IDs, so we instead relied on Medicare claims to characterize the market structure, to characterize the amount of integration at an MSA level, and then merge that in with the market scan claims. In the end, we had about 7.4 million PPO enrollees, as well as some POS enrollees, that's point of service plan enrollees. We focused on the MSAs where there was more substantial overlap between the providers captured in Medicare claims and the providers billing in the market scan claims. And we also made some restrictions to enrollees that were continuously in the database to limit any compositional changes in the providers or the segments of the markets that we were capturing. To measure physician-hospital integration from the Medicare claims, we exploited this feature of Medicare payment that Ann mentioned, which is that a service rendered in a hospital-owned facility is reimbursed at a higher rate, often substantially so, than the same service down the street in a independent office setting. And that is true of hospital outpatient departments can receive that higher rate, as well as off-campus hospital-owned practices. In order to receive that rate, however, the place of service code in the claim needs to be changed from office to hospital outpatient. So we exploited that strong financial incentive for there to be a change in the place of service code in order to measure in any given MSA the proportion of physicians or national provider identifiers who were billing in hospital-owned facilities. That was our measure of vertical integration. Now that misses some acquisitions. The place of service coding does not always change for various reasons. It also misses looser contracting arrangements, for example, physician-hospital organizations that involve joint ownership. We then constructed more standard measures of physician, hospital, and insurer market concentration using taxpayer identification numbers, or TINs, as a poor man's identifier of physician practices, and using the databases listed here for each of those measures. We used an implied price approach to decompose spending into its components of price and utilization. So what we did is we could measure spending directly, inpatient and outpatient spending. Then we constructed a utilization measure, which was really a measure of price standardized spending. So for each enrollee, we created a count of each service and then multiplied that by its mean national price. So we can then know, because we know that spending equals price times quantity, that if there's a spending increase, but we don't see a quantity or utilization increase, then there must have been a price increase. So we did this without directly measuring prices. And then we measured several covariates at an MSA level, patient level, and plan level. Our analysis essentially consisted of a regression model of the spending or utilization variables as a function of the year and MSA fixed effects, the vertical integration measure, and then some the measures of market concentration, as well as the covariates. So with the year and market fixed effects in there, we are essentially identifying the effects of vertical integration off of the differential changes in integration that occurred across the different areas. So it turns out there was a lot of geographic variability in the amount of vertical integration that occurred. So you can think of this model as testing whether one market that experienced more vertical integration exhibited a greater price increase or spending increase than a market that experienced less vertical integration. Now, as with any study of this design, the strength of the conclusions really rests on whether there are changes in other things that are correlated with the thing that you're interested in, and if so, how well can you control for those changes. This table lists all the predictors in our model and essentially demonstrates that the vertical integration, the changes in physician-hospital relationships, was not really related to changes in any of the other things that we could measure. So just walking through the top row here, in 2008, the average MSA level amount of vertical integration was 18%. That's 18% of physicians billing in hospital and facilities. That rose on average to 21.3% in 2012. That seems like a small increase, but there's a lot of variation underlying that. We then categorized the MSAs into those that experienced less than the median increase in vertical integration versus more than the median increase. And so as you can see here, below the median, those MSAs, really nothing was going on. In fact, there were some divestitures. Versus above the median, a much greater amount of integration, 6.8 percentage points. Then looking down at the other characteristics, whether it's physician market concentration, hospital insurer, the MSA level sociodemographics, supply variables like physicians or hospital beds per capita, the mean patient DXCG risk score, some measures of plan generosity that we constructed. The changes in the areas experienced more versus less integration are very similar, as indicated by the estimates and the p-values up here. So this is not a randomized experiment. We cannot make absolute causal claims, but the effects we found do seem to be strongly related to the vertical integration occurring. So here are our main results for the effect of vertical integration. What we did is we reported estimates in terms of what one would expect for the MSA experiencing a change at the 75th percentile of changes. So where there was something going on, not an extreme amount, but somewhere in the middle of the MSAs where there was more integration, what would we expect? And that turned out to be a 5.2 percentage point increase. So for that amount of integration, that was associated with a $75 increase in outpatient spending. That is about 3.1% of the overall total annual outpatient spending of about $2,400 per enrollee. If you then, and that sounds quite small, but that's only with 5% of physicians integrating. If you think about a market going from no integration to full integration, the estimate would be more like $1,400 or $1,500, or about 60% of outpatient spending. That's also equivalent to thinking about what would happen to spending for a particular patient if their doctors went from not integrated to integrated. Then in blue, the utilization effects you can see are minimal. So this suggests two things. One, no compelling evidence here of any efficiencies from vertical integration. And secondly, that the outpatient spending effect must have been almost entirely due to price increases. We then find very little going on the inpatient side, although things are positive. Suggesting a small price increase consistent with some prior studies. And we expected this greater effect on the outpatient side for a couple reasons. One, because of the higher payments in Medicare, it turns out that payment differential between hospital-owned and independent office is transmitted a lot into commercial rates on the commercial side. So just mechanically, by having more hospital-owned practices or more employees and HOPDs, we should see a price increase that is unrelated to any market power story. In terms of a potential market power effect, we would also probably expect a greater effect on the outpatient side, because if you go back here and look at the hospital concentration measure, it's got a Herfindahl-Hirschman index of about 4,000 versus the physician HHI, which is only 600 or 700. So that just goes to show how much more concentrated the hospital market is than the physician market. So if you think about acquisitions, the average transaction going on here is a big hospital system with a substantial market share acquiring a physician practice with not so much market share. So there's more market power conferred from the hospital to the physicians when they negotiate for outpatient services than from the physicians to the hospitals involved. We couldn't disentangle those effects, but we did an analysis to try to just test whether market power was contributing to the price increases. So here are the payment differentials or price differentials for office visits, the differential between independent versus hospital loan for each MSA in the market scan, commercial, and the Medicare population. And we ranked the MSAs from smallest to largest in terms of their market scan price differential. So as you can see, the red is Medicare. I think that fell off the slide. As you can see, there is some variability across MSAs in the price differential in Medicare. We expect that because there are geographic wage adjustments to Medicare payments. If market power was not contributing to the higher prices in the vertically integrated setting, then we would expect about the same amount of variation on the commercial side as well. But instead, we find much more variation. So in Medicare, the differential ranges from about $35 to $100. In market scan, from about $35 to $200. So strongly suggestive that there's something else aside from that sort of quirk of the Medicare payment system going on, and that something else really must be bargaining power. So I'm just going to skip over this in the interest of time and move on to some recent work that we published last spring comparing, among other things, vertically integrated organizations participating in the Pioneer ACO program to the independent physician groups participating. Here we have plotted savings, so from right to left is more savings. This is just total savings. And as you can see, for the groups with financial integration between hospitals and physicians, the savings are essentially identical to those with comprised of independent physician groups. The results from the study I just showed you are during a period in which there is very weak incentives for vertically integrated organizations to achieve efficiencies, so perhaps we shouldn't expect them. Here we're sort of testing, at least early on when those incentives are in place, do we see those efficiencies, and certainly not manifest yet. In fact, if anything, we found regardless of organizational structure, it seemed how inefficient the organizations were at the outset in terms of their spending predicted savings. And then finally, here are some preliminary results from some ongoing work we're doing to try to get at this question of whether payment reform is contributing as a major driver of integration. Here's our measure of vertical integration on the y-axis. We categorized MSAs according to their 2013 Medicare ACO penetration. So a few things to note here. First is that integration is rising in all MSAs, in all the groups of MSAs during the whole period. It's already on the rise before the ACA passed. The MSAs with the greatest amount of ACO activity by 2013 were the most initially integrated, which is probably not surprising. For the two highest quartiles, that's the purple and green lines, those are MSAs with the most ACO contracting in 2013. Doesn't seem to be any acceleration in the amount of integration in preparation for many of the providers in those markets entering ACO contracts. Maybe a suggestion for the MSAs with lower levels of integration, as if providers are sort of integrating to gear up to participate in ACO models thereafter. But I think certainly nothing seismic going on here, no compelling evidence that integration is being driven by payment reform, at least not yet. So in conclusion, vertical integration we found was associated with higher prices with no evidence of efficiencies under either fee-for-service or so far under alternative payment models. Not clear that integration is accelerating under payment reform, again, at least not yet, but it is clear that it's increasing and having an impact on prices. Even if we find that payment reforms are contributing, I don't think this is necessarily a reason to abandon those important reforms, and we'll discuss policy implications more, but I think suffice it to say there's a need, regardless of the source of the consolidation, a need for parallel or complementary policies to keep markets competitive and limit markups. I tend to think more of the supply side strategies are probably going to be more effective than the demand side strategies. And then just to note that more competitive hospital markets may be key to limiting the price increases from vertical integration. All right, thanks very much.
Thank you, Michael. Jim?
Okay. I've been trying to get over a cold this week, so hopefully I'll make it through the presentation without starting to hack into the microphone. I think the paper by McWilliams and its colleagues is very good. The promise of hospital employment of physicians or vertical integration is care improvement to lower costs and improve quality. The McWilliams paper is one of several that now indicate the vertical integration is associated with higher costs, not lower costs. And the impact on quality has not been extensively studied. There's one study that does show that does associate hospital employment of physicians with patients receiving care in lower quality hospitals. McWilliams and colleagues identify higher outpatient prices as the main driver of these higher costs, and I think this is a key contribution to the paper. That said, there are two cautions in interpreting the results. The paper presents an average effect, and we need to be cognizant that there's a lot of variation that's going on behind the mean in terms of what hospital systems are doing with their employed physicians. There are more than a few hospitals that are in fact going down the path of creating integrated healthcare systems and delivering higher quality care, but this study results suggest that this may not be necessarily the norm. Another caution in looking at the results is that the landscape is rapidly changing. The study used data through 2012. However, the number of ACOs has more than doubled since then. Now, while I doubt that the results would be radically different with more recent data, nor should we assume that the results are going to be static over time. The study's results suggest that vertically integrated hospitals increase revenue primarily by using enhanced market power to negotiate higher rates with commercial insurers for outpatient services, shifting outpatient services from the community to the HOPD, where they receive higher reimbursements, or not shifting the location of where services take place, but instead billing off-campus community-based services as if they were provided in HOPDs and hence receiving higher reimbursements. Although the McWilliams paper looks at the effects for commercially insured patients, the increased billing of services at higher hospital outpatient rates could affect public as well as private payer costs. For instance, the median complexity office visit in the hospital outpatient department costs about 70% more under the Medicare fee schedule than if the same visit was billed at the community office-based rate. A couple years ago, I did a little study in which I took some commercial claims data from the auto industry and compared prices of outpatient services billed at the hospital outpatient rate compared with those billed at the community rate. This slide shows the costs of knee MRIs in both settings, and the horizontal line is the mean. On average, HOPD prices were about 50% higher than prices in community for community-based providers. This slide shows various variants of screening colonoscopies. Here, HOPD prices are on average double that of community rates. And this slide shows prices for 3 very common and relatively expensive lab tests. Mean HOPD prices are 2 to 3 times community prices on average, but noteworthy is the long tail on hospital outpatient prices. Some hospitals are charging 8 to 10 times the community rate. Moreover, price differentials varied considerably across metropolitan areas, consistent with one of the charts that Michael showed in his presentation. Now, another reason why we might not expect hospital employment of physicians to result in lower costs within the time frame of this study is that transitioning to an ACO or other alternative payment model is really tough and it takes a long time. To succeed as an integrated system typically requires building new interoperable information systems, care management, quality measurement systems, population health management systems, as well as devising ways to align provider incentives. While these are all important and difficult components, the success of ACOs may more fundamentally rest on leadership, organizational culture, and governance, things for which hospital-led systems do not necessarily have any inherent advantage. All that said, hospital-led ACOs have some distinct advantages, as Ann and Michael mentioned. Because of the employment relationship, they presumably have a greater sway over provider behavior, and they tend to have greater resources with which to create integrated delivery systems. There are some aspects of hospital-led systems that may make it more difficult for them to succeed in the ACO space, at least in the near term. First, ACO transition requires a fundamental change in mindset. The hospital's traditional books of business, that is inpatient and hospital outpatient services, will need to be thought of as cost centers, not profit centers. And this is not an easy pivot in thinking for a hospital administrator. Secondly, short-term routes to profitability under the ACO model may be more difficult to achieve for hospital-led systems. And this is because that ACOs are built on a fee-for-service chassis. And the most lucrative way to achieve ACO savings is by cutting use of services by providers who are not included in your ACO network without necessarily cutting your own fee-for-service revenue. For example, one way that physician-led ACOs might achieve savings is by reducing ED and inpatient use by patients, or shifting the site of services from hospital outpatient departments to community-based providers. Another way would be to better manage post-acute care. Hospital-led ACOs may subsequently have greater opportunities to do this than hospital-led ones. And there's some anecdotal evidence that physician-led ACOs are meeting with greater financial success than hospital-led ones on average, although that doesn't seem to be the case in the Pioneer program. On the other hand, the higher hospital system outpatient prices could lead to higher ACO benchmarks and hence an easier road to shared savings by hospital-led systems. Because they're starting at a more expensive rate, it's easier to achieve savings. So where do we go from here? There will be continued pressure from CMS and commercial payers for doctors and hospitals to work closely together to manage patient health and lower costs. The Medicare Access and CHIP Reauthorization Act of 2015, or MACRA, which was passed this spring, will make continuing under fee-for-service less attractive and APMs more attractive. Moreover, CMS is showing some signs of a greater willingness to compel providers to participate in APMs. For instance, the new Comprehensive Care for Joint Replacement demonstration, which is a bundled payment initiative, is compelling hospitals to participate in 25 metropolitan areas. And there are also signs that CMS may be more willing to move away from provider-specific historical benchmarks in shared savings and shared risk arrangements, arrangements that now somewhat reward inefficient provider systems. In addition, the recent budget deal marks an initial move to limit HOPD pricing for off-campus community-based services by employed physicians. The budget deal only applies to newly employed physicians, but on the other hand, there have been other calls, such as by MedPAC, to more broadly limit this practice. So a reading of the tea leaves suggests that vertically integrated hospitals that fail to pursue integrated delivery systems to accommodate for alternative payment models do so at their own peril. So that's it. Thank you very much.
Thank you, Jim. Stu?
Thanks, and thanks to both of you for very interesting information and observations. I'm going to take a step back a little bit because when we talk about integration, whether it's vertical or horizontal, there's this presumption of the existence of markets in healthcare that I think needs to be further, more closely examined. So I want to point out there are two types of markets in healthcare. There's a market for healthcare services, which is the one we usually talk about and worry about, and there's the market for healthcare coverage, and that's been getting more attention lately with the proposed mergers of some major national health insurers, and there's some concern about the potential impact of that as well. And there's also there's some literature that indicates that consolidation in the health insurer market lowers the prices that providers can charge, but then there's also a question about whether that translates to lower premiums for the consumer in the healthcare market. So we need to kind of keep these two markets in mind and understand that they interact. Another thing we need to understand is that when we talk about markets, we have to kind of use that phrase with a grain of salt because I think both of these markets could be argued to be broken. So in particular, when you see policy recommendations that would rely on market mechanisms to kind of take care of all the problems of our healthcare system, we've got to be fairly skeptical about how those would work in the markets that we have for both healthcare services and for healthcare coverage. For one thing, in Economics 101, we always teach our students that one condition for a perfectly competitive market to function well is perfect information, and we know that that's not the case. And even though we are moving in the right direction, I think over the last several years, we're still far from having the kind of information that would really support a highly functioning set of markets. Also, we still have adverse incentives, many of which have been mentioned in the first two presentations here, that lead folks in a direction that I think is contrary to where we as a society would like to see the healthcare system move. And of course, as is often mentioned, there is a disconnect between the purchaser of health services and, in fact, of health insurance and the user of each of those commodities. And that distorts the decision-making process and also distorts, hinders the reaction that we'd like to see to changes in how we pursue policy in those markets. So as we're seeing, both markets are becoming more consolidated. And I would argue this trend could be both good news and bad news, and I think we've seen the upside and downside of that mentioned in these two presentations by Michael and Jim. We need to understand that, and I think we need to focus a lot of competition policy tends to focus on more competition versus less competition, or even more, in a more binary sense, whether we should let mergers take place or whether we should just prevent them from taking place, as opposed to what we might be able to do to make these markets work better. And I think we need to really focus a lot on that. It struck me, especially during the debate when the Affordable Care Act had just been passed, and there was a lot of discussion about what the implications of the ACO model would be for healthcare competition, because of the natural tendency to think that consolidation would be good to informing an ACO, but the natural fear that folks have about what the implications of that could be for prices. And at this point, I guess I'm struck by the fact, I was struck by in looking at the composition of this panel, that I've often heard it said that Washington is full of economists who are pretending to be doctors and doctors who are pretending to be economists. And I guess there are some folks who actually legitimately could claim to be both. But in the field of competition policy, I guess we could say that doctors and economists both can run around pretending to be lawyers. So that complicates the matter a little bit. So what are the implications for policy? I think it's clear that we need to work harder at pushing along the path that I think we've started on, which is aligning payment incentives with system goals, what I describe as paying for what we want. I think we generally have seen evidence that we get what we pay for. The problem is that for the last 50 years, we've been generally paying for the wrong thing, for something that we don't want. And I think observations that I'm glad that it was pointed out that consolidation started before the ACA was passed. One might actually draw comfort in the fact that maybe the consolidation that's happening now might at least be motivated by the right reasons rather than what folks were being paid to do before, which was just generate more revenue and more utilization. That might be unnecessary. We need to focus on making markets work. There's a lot of argument about what markets mean. I like to distinguish between market forces, which are kind of a force of nature that that tends to pull resources in particular directions in reaction to policies and actions and stimuli of other sorts, and the markets themselves, which are the structures in which these market forces operate. And I guess the example I usually use is hydraulic power, which is a very powerful force of nature. But if it's not appropriately managed and controlled, it can be very destructive. If it is appropriately managed and controlled, it can actually be very productive. And we need to view markets that way. We need to set up markets so that when we let the market operate, it will produce the results that society wants to see. And that doesn't happen automatically. And I think that's something that needs to be brought out more clearly when we talk about competition policy. Some of the ways of trying to balance competition and regulation, because that I think the proper mix is what we need to kind of strike a balance between. Narrow networks help bring price pressure to bear, although narrow networks make me nervous only because I remember hearing a national health insurer state very proudly that they had great faith in their ability to steer, in a new initiative, to steer their subscribers to higher quality, lower cost providers. And then when somebody in the audience asked, what proportion of your providers do you flunk out of your network on the basis of quality, the answer was 4%, which meant that they were steering their subscribers to low-cost providers, not high-quality providers. So we need to really pay attention to how those narrow networks are put together. They're neither good nor bad, except in how they're implemented and developed. Tiered networks is similar. Reference pricing has been shown to work in some kind of more easily defined services. Paying attention to benefit design is really important. One thing I've observed, I've spent most of my career working on the Medicare program, and it occurs to me that with all of the action going on in payment reform in Medicare, which is basically trying to make sure that providers are facing the right incentives, there's really very little of that carries over to what faces the beneficiary in terms of benefit design, in terms of perhaps shared savings for participating in alternative payment models through their providers. There's this disconnect has to be reconnected because, I tend to view it as in a positive light, not punishing beneficiaries for making the wrong choices, because frequently they don't have the information to make the right choices, but providing them with better information and providing them with more positive incentives to look for care from high-value providers. Price regulation, I've been working a lot with the folks in Maryland, which is the rate-setting state, and there have been some interesting results in the latest iteration of their payment reform efforts. And then, most of all, again, fixing the infrastructure of the markets in which all of these transactions take place so that we can feel more comfortable that the incentives that are put into place are going to produce the kind of behavior that we'd like to see. So thanks, and I'll hand it over.
Thank you, Stu. Craig?
Hi, good afternoon. So my job is to drill down a bit into the Medicare ACO world. I'm the project director for 2 contracts that Mathematica has with the Center for Medicare and Medicaid Innovation to run national learning collaboratives for Medicare ACOs. So I just want to share some thoughts and observations about what we've learned in working with those organizations. So first, a bit of a primer on what we're talking about when there's Medicare ACOs. My observation has been when most people think of Medicare ACOs, they think about the Pioneer program. And there's been an enormous amount of ink spilled on it is a fact, that the Pioneer program has gone from the initial number of 32 down to 19 today. And so there's been an enormous amount of talk about why pioneers are leaving the program. But there are other Medicare ACO models. There's the Shared Savings Program, and there are more than 400 clinical organizations that have signed up for the Shared Savings Program, and something like 75 to 100 come on each year. So this is clearly, unlike what some of the press reports might lead you to believe, this is not a failed program. This is a growing program that clinical organizations are finding attractive. Within the Shared Savings Program, there are 2 subsets, Advanced Payment and ACO Investment Model, or AIM. So one thing that we've already heard, it's not working? A little extra. Well, I thought I was talking loudly. Sorry. As we heard earlier, ACOs need investment in infrastructure to start up, to do your data analysis, to hire care coordinators, that kind of thing. And what the advanced payment and the new AIM model do is provide that funding, meaning CMS provides that funding to the organizations, and then hopefully that money is paid back out of future shared savings. So that's what those are. And then just in October, CMS launched a new kind of ACO specifically for the end-stage renal disease population. So definitely a new kind of idea to target a particular disease group. So that's, just started last month. So we're definitely interested in seeing how that plays out. And then coming in January, we're going to have the new next generation model, which is essentially the sequel to Pioneer 2.0. So this slide, there's way too much on this slide to go over. But it does present all the models so that you can compare them based on when they started. And one thing about the Pioneer program, well, why has the number gone down? Well, there was only one chance to join, so it could only go in one direction. But the Shared Savings Program, as I mentioned, has an annual enrollment opportunity for the ESRD program known as ESCO. Currently, there are no plans for expansion, but that could be subject to change. And next generation, there are two windows. So there's a January 2016 cohort, and then there will be a January 2017 cohort. No additional enrollment opportunities are currently planned. Again, I can't walk through everything on this slide, but I did want to point out on that payment row, which has a lot of acronyms and numbers and percentages, I think that the main takeaway there is CMS created a lot of options for healthcare organizations to try and choose which model fits best for them. So there isn't a one-size-fits-all approach at all. Even Pioneer, just 32 organizations, they had 5 different options. So the theory is that organizations could find the payment model that fits best with their organizational structure, their patient population, their tolerance for risk. So there are a lot of opportunities there. So this is a slide I've used a number of times, but I reorganized it for today. So actually, you read this and see the number of challenges ACOs face. You might ask, why would anyone want to do this? And the reason is because it is an opportunity to transform care. What we hear from a lot of ACO staff is, this is what we've always wanted to do. This is the way we want to deliver care. Finally, the payment system is enabling us to change that delivery model. But it's really hard. So on the left column are just a number of challenges that we've heard through our conversations with ACOs through this project. What I put on the right side are what I think of as the challenges that are really particular to this issue of vertical integration. So building provider networks in rural areas, well, that would lead to vertical integration, I would think. That if you want to be an ACO and you need to meet CMS's access to care criteria, then you need to find some way to align with practices in diverse geographic areas. Organizational transformation, again, you're changing this whole mindset from the fee-for-service volume-based to value-based. So if you're adding new organizations, it makes that much harder. So I think that's actually kind of a disincentive to the integration approach. The EHRs and interoperability, again, that's the bigger you grow, the harder that becomes. That's a disincentive to growing. Data sharing, I think, actually works both ways. So the rationale for doing the vertical integration is you add on resources that give you the infrastructure to create the systems and do the data analytics, because the most important kind of provider engagement piece we hear about is giving them real-time actionable data. So you need some sort of structure for doing so. But part of that data sharing is, how do you collect the data to begin with? And the bigger and more dispersed and diverse your organization, then the harder that becomes. And then one of these challenges is completely related to this topic, is integrating newly acquired organizations. So it's not just how do you change their mindset, it's how do you bring a new organization into an existing one and have a unified corporate culture and value system. So just some thoughts I put together in reading Dr. McWilliams and colleagues' papers. So there were some organizations that merged just for the purpose of becoming Medicare ACOs. So there was definitely a driver in that direction. I have heard a theory, I'm not sure I agree with it, but I've definitely heard it expressed, that what some providers think is the winning game is Medicare Advantage. And so get in on the ground floor of the shared savings program, which has no downside risk, learn how to manage risk, and then you can move into Medicare Advantage, which from their perspective is going to be more lucrative. May or may not be true. The third point, I think we've heard other speakers address. I want to point out on the vertical integration issue, it's not just hospitals and practices. At some level, ACOs need to work across the entire continuum of care. So it's nursing homes and home health agencies and rehab facilities. And so they're not necessarily buying up these kind of facilities, but they do need to make some sort of partnership or referral arrangement. So it really is broader than just physician offices. So what is Medicare policy pushing providers to do? One thing it is clearly pushing providers to do is move up the ladder of risk. So for example, thinking about, from shared savings program to Pioneer to Next Generation, those are ladders of accepting risk. And so there's definitely a belief that that is the way the delivery system needs to go. One thing I think it's important to think about is patient engagement. Patient engagement is a tough nut for ACOs to crack, and arguably no one has really done it yet. And part of that is because if you think back to that slide with all the stuff on it, the attribution methods are for the most part retrospective. So unlike Medicare Advantage, where patients affirmatively enroll in a program, CMS tells the ACOs who your patients were at the end of the year. So it's really hard to figure out how to work with them, and then if you invest some of those services, one of your competitors might recoup the long-term gains. So I think we're running a little late on time, so I just want to wrap up with this comment. So one of the things we're doing in our project is bringing together ACOs. We bring together the Pioneers and Next Gens and ESCOs on a once-a-year national basis, and we're bringing all the models together once or twice a year on a regional basis, and we just had the meeting in Boston the other day. And I heard this quote, and I will point out it was from a chief operating officer, not a chief financial officer. And she said, "Healthcare is a noble purpose. It can't be about you. It's got to be about the patients. If you just want to make money, go sell shampoo."
Thank you, Craig. And last but not least, Jean Rich, who is the director of the center.
Thanks, Ann. And I appreciate that I'm the one who's between you folks and this great panel that you'd like to talk about these findings with. So I'm going to be very quick. I really wanted to just direct your attention to some relevant resources on the topic of economies of scale of physician practice, because as you've heard, embedded in all this is the idea that maybe you will make physician practices more efficient and better quality if they are somehow acquired and integrated into systems. And so for some work that a group of us here at Mathematica did for ARC on collecting data on physicians and their practices, we had in August of this year a series of articles in the Journal of General Internal Medicine, two of which speak to some of the issues that we've talked about today. One on measuring changes in the economics of medical practice that I'm going to refer to, and another on factors contributing to variation in physicians' use of evidence, which was led by Jim Rashofsky. In our review on the economics of physician practice, we sort of went over the broad range of studies over the last 30 years on production and cost functions of physician practices. But if you're interested in this topic, I would really commend to you Lawton Burns' article in 2013. I'm giving you two great quotes that come from this that are, I think, relevant to our topic today. One, after reviewing the extensive literature on these topics, they conclude evidence of scale economies, scope economies, and quality performance advantages for consolidation of physician practice has been strikingly thin in some cases for decades, and that scale economies appear to be quickly reached by groups of 10 or so physicians. And it's perhaps helpful to remind you at this point that many industrialized countries still today achieve better quality and lower costs through physician practices that are largely small, single specialty groups. So, there's no evidence from other industrialized countries that physician acquisition by large systems is required to produce desired results. And this is just an alert. This is through 2014 physician compare data, looking at the top physician specialties billing the Medicare program, that there are a number of important specialties where in 2014 physicians were billing the Medicare program through practice organizations defined by 10, as Michael McWilliams' study did, where many physicians in that specialty are in practices of 15 or fewer. And that 15 or fewer is an important figure in MACRA. That's sort of the focus of MACRA on small physician practices, including 70% of ophthalmologists and almost 70% of dermatologists practicing in groups of 15 or fewer. I won't go through this complicated diagram. It's really just a way of alerting you to the fact that when you think about an individual specialty physician practice, the work that they do is subject to influences at their practice site, at the organization that owns and employs them, the various affiliations that they have, and that from a patient perspective, what they're looking for from that specialty physician practice are some fairly straightforward things like timely evaluation, correctly interpreted diagnostic tests, patient-centered recommendations, and well-executed therapeutic interventions. And it's probably not realistic to think about the production of a dermatologist or an interventional cardiologist as achieving population health. What they do is something more focused and yet very important. That when these practices get embedded in large organizations, there are, as you've heard, powerful tools that those organizations can use to both advance improved care but also complicate it. And that some of those, like work culture and peer relationships, don't transform overnight just because you've acquired a physician practice. And that there are a lot of ways in which organizations can create complications in terms of workflow, time schedules, support staff, that may not necessarily improve physician efficiency. In the article on economies of scale and scope, we sort of emphasize, given the current complexity in the physician practice landscape, how difficult it will be to reproduce the studies from the 1970s and 80s on economies of scale and scope. I won't belabor that here, but commend that to you. And just conclude that understanding the economics of medical practice, we think, remains important given the continued diversity of physician practice arrangements and their implications for payment reform. That the evolving environment for physician practice imposes some significant research challenges to disentangling the economies For example, the diverse affiliations of practice sites with all kinds of entities like ACOs and like affiliated hospitals are going to complicate collecting the data on inputs and outputs, because these may be held by several different organizations. But there is the opportunity through all payer claims databases and data sharing consortia to start to probe in some of these directions, and perhaps a consideration for future research. So I will not slow us down and let us turn to the panel.
Okay, thank you, Jean. So I just want to, we're going to start off by asking a couple of questions specifically to our panelists here for their brief responses, but I want to remind the webinar audience to please go ahead and submit your questions so that we can make sure that you're heard as well as those here in the room. And I want to also remind the panelists to turn their mics on now, because we want to hear your responses to some of the questions we have here. So first, I'll pose this to all of you, and anyone who wants to respond, feel free. Why should policymakers be cautious about pursuing large integrated systems, especially those led by hospitals, given that existing research does not support that this leads to lower costs or more efficient care? And I will, whoever wants to go first, please speak up. If you don't, I'll just ask somebody.
I'll chime in quickly. So I think both Stu and I made the point that, you know, we've been studying this in a fee-for-service world for a while now, and there are no efficiencies that have been found, but we're just starting a new era of new payment models, and it'll be 4 or 5 years, I think, before we can determine whether a particular organizational structure is or is not supporting the goals of those payment models better than in other organizational structures. So.
And okay, I'll jump in too. You know, I think that we get size is easy to measure, but the fact is the size doesn't. I don't expect that size will be a determining factor. I think it's a matter of how well the organization can handle achieving the goals that it wants to handle, and how well payers can handle manifesting the goals of the system through the payment reforms that are being implemented. Jean mentioned I think Jean mentioned the other country, the fact that most practices are small in other countries. When I was at the Commonwealth Fund, we were doing an analysis of that with one of our international surveys, and we told the programmer to sort out practice characteristics and achieved efficiencies and quality by practice size. And we got a frantic call back from the programmer that said, we have a problem because in these other countries there aren't any large practices. So we aren't able to, most of these cells are empty that we put together in this table. But the thing that struck me then was not that small practices are necessarily better than big practices, but why we think big practices are good in this country is that in other countries the small practices have a system to plug into that they don't have in this country. So we need to figure out a way to make the system work better and to really look at the fact that it's not small versus large, but efficient versus inefficient.
Having an infrastructure to support those practices. Craig, Jean, Jim, any other thoughts?
Oh, well, I'll just reiterate sort of what I said, which is that there's considerable evidence that you get what in the old literature they called bureaucratization costs once you get practices of over 10 to 15. You know, how many committee meetings do you want your interventional cardiologist to be spending their time in, as opposed to doing what they like to do and what they're really good at? Of course, our problem right now is that sometimes they're doing a lot of interventions, whether those are adding value or not, and we're trying to sort of figure out how to right-size that. But that's the challenge. How do we make sure that we're creating a system where we're making the efficient use of the talents that are out there in the practice community? And also, of course, there's the caution that, well, even if a larger organization is desirable, is it really an organization that grew up to manage inpatients and specialized inpatient services, that's the logical one to improve the efficiency and management of a population of patients.
And we know that the majority of care does not take place in the hospital. The majority of costs may come from the hospital, but the vast majority of patient interactions are in the outpatient setting. So. Okay, one more question for the panel, and then we'll open it up to audience and Q&A. So how can current payment reforms impact integration efforts and vice versa? Okay.
I'll start off if no one else is jumping. So as I mentioned earlier, and some of the other speakers pointed out, infrastructure is needed to move into the value-based care world. So the first part of that answer is those care coordinators, right? The whole idea is to do what fee-for-service does not pay you for. So the care coordination is a piece of that. And the other is what might be called non-medically necessary services, right? Medicare is based on the principle of we pay for what is medically necessary, which sounds appropriate, sounds like it's against fraud and abuse, but what it means is that you don't get to provide ancillary holistic services to the patients that may alleviate the need for more acute services down the road. And that's what accountable care and other payment reform models enable these clinical organizations to do, is invest in the processes and resources that prevent worsening of health and greater use of more acute services.
I'd add too that there may be limits to what we can do with payment policy in that direction. So it may actually call for more government action or more community action to provide the kind of support resources that are community goods that all providers and patients can draw on. And I think because it's hard to figure out how to pay. I mean, the best example when I was at CMS is, people always talk about paying for emails or calls to physicians, but of course that would make anybody at CMS turn pink because they have to think about, okay, once we pay for these things, we'll get lots of them, whether they're any good or not. So one way to address this is to understand that we need to spend more money on social services that can help support better health outcomes. And I think the book by Elizabeth Bradley and Lauren Taylor kind of points out that in the U.S. we spend precious little on social services that are related to health.
Okay. Should we walk a microphone over? People are starting to get here. Okay. So we have someone who will bring a microphone to the audience here in the room, and then we'll alternate with webinar.
I want to make sure I'm holding this close enough. I have a really basic question here. We're talking about physicians being employed by hospitals and vertical integration and so forth. What percentage of doctors are employed by hospitals? And what's your definition that goes with that number? I think Michael has as a 21% figure, but I've not seen a lot of good evidence of how large this animal is, which we've been talking about.
I think the numbers are all over the map.
Yeah.
And, who knows what the methods are. I mean, certainly there have been some surveys with very small, very low response rates that come up with numbers, but I wouldn't put a whole lot of stock in any particular number at this point. We just don't know, I don't think.
So in our estimate, the 21% was actually an average of MSA level mean. So if you just look at the physician average of what proportion of physicians in the country are exclusively billing in hospital and facilities, it's more like 25%. And so given that we're missing a lot of other, a lot of relationships that may approximate someone's definition of ownership or employment, or at least joint contracting for price negotiation purposes, that's a lower bound. I've heard estimates as high as 50% from MGMA, for example, but I'm not sure if that really fits with my gestalt of the world.
Well, ignoring the problems with data, what's the concept? How do you determine whether a practice is owned by a hospital or not? If you're able to go there and kick the tires and ask questions.
I think other than the claims, you would have to do exactly what you're saying.
But if you had that opportunity to talk to the lawyers and so forth involved, conceptually, how would you distinguish between a practice which is owned by a hospital and one that's just sort of affiliated with it?
We wrestled with this for the Collecting Data on Physicians and Their Practices project, and this will not fully satisfy you, but we decided that the first most important thing to learn is who employs the physician, who determines to whom are they contractually obligated for their terms of employment, and who sets their compensation. Now, as I think you know, there are some circumstances where, let's say, for example, an academic health center, where there may be a holding company that owns both the hospital and the physician practice. The physicians are getting their paychecks written in their terms of employment by the physician group. But at least in that sense, those physicians may not be owned by the hospital. But I think in the other circumstance, Michael, I'm anticipating you'll point this out, that sometimes those physicians who are not owned by the hospital are working out of hospital outpatient departments, which looks like a pretty close affiliation.
That's right, and that happens. Actually, that's how I function as a physician. So I receive my paycheck from a physician's organization, not from the hospital, even though I am practicing in the belly of the hospital. And that happens not infrequently, even off campus, where the hospital will own the practice and employ the staff, but not the physicians, and the physicians have their own group that's independent. For Medicare reimbursement purposes, they can still get, the two entities can still get the higher HOPD rate in that case, because the facility is owned by the hospital, and that's the key thing, but there is no employment relationship.
I could go back and forth on this, but I've used enough of my time.
Thank you. How about a question from our webinar audience?
Yes, we do have a question from Roberta Shapiro. Can the group talk more about the bundled payment program relative to vertical integration? Is this a program that, while narrow, is more likely to align and focus incentives?
Well, I mean, the bundle payment demonstrations, and there's the bundle payment for care improvement, and now the new one focused on joint replacement, are triggered by hospitalizations. So you don't have the sort of population health focus that you would have in an ACO. But to the extent that it creates an incentive for the hospitals to work with admitting physicians and, very importantly, post-acute care providers, a lot of the same kinds of demands on the participants in the bundling demonstrations do exist. And I think what we are finding is that, and this is somewhat consistent with the point that I made during my presentation, is that a lot of the savings that are being realized in the bundled payment demos are in terms of post-acute care. Previously, physicians would do an operation and they didn't really have anything invested in whether the patient went to the most appropriate post-acute setting, whether anybody was caring, how long they stayed there, and so on and so forth. Now, under bundle payment, where that may be, depending on the model, part of the bundle price, there's an incentive for the provider, the hospital, or the physician to really focus on all of the costs throughout the entire episode.
And it's not just the cost. From the patient's perspective, it used to be that you'd come to the end of your hospital stay, and there was just a cliff you dropped off. And I kind of, having gone through this with family members, I kind of conjured up the last scene of Gone with the Wind, where the patient says to the healthcare system, doctor, where will I go? What will I do? And the answer was just as in the movie, frankly, my dear, I don't give a damn. Now there's, under bundled payment, there's an incentive for those people to talk to each other and also for them to worry about what happens to the patient after they leave the hospital.
Tim?
I was trying to phrase this as a question, but I think I wanted to make I'll make a statement that, that sort of one takeaway I have from all the great presentations, and just see if you agree with it or have comment on it, which is that I think you can look at a payment reform and the different kinds of payment reforms we've been talking about and relatively easily determine what it's trying to do in terms of service delivery. What kinds of areas of quality it's trying to address, what kinds of service changes it's trying to make, but that it's not clear at this point either what effects it will have on acquisition or of vertical integration or prices as well, or costs. Is that? Well, I just want to see if people have any reactions to that. My sort of takeaway of when you look at a particular payment reform, what you see there.
Well, I'll respond first, and it also connects to the question about bundled payment. And that is, I think that I think it's possible to analyze what may happen under some payment models, and I'm going to use the bundled payment example. Stu has pointed out the benefits that occur with episode-based payment. But what you could anticipate would also happen would be a further creation of what have been called focused factories, of sort of a collusion of hospitals that are interested in, say, doing joint surgery and physician practices who are also interested. And they now are being very efficient at delivering a unit of joint surgery, but they also become very efficient at finding everyone in the community who might plausibly be a candidate. And I think that one could see there are certain kinds of payment models where that is sort of depending on how you define the bundled payment, a rather predictable and not necessarily socially desirable outcome. There are others where I would say the potential effects are much more complicated, particularly given the diversity of current arrangements across markets.
I think there's no question that there will be some lower level of integration. I mean, solo practitioners just can't become an ACO. And so some small or some low level of integration almost seems necessary in order for these payment models to be rolled out on a widespread basis. I think what's more concerning, though, are some of the mega mergers or hospital systems sort of picking off practices one by one and then becoming sort of a dominant player in a market. And in an ideal world, we would have sort of a market structure that forms de novo now with the right incentives put in place, and the winning model would win, and that would be sort of the dominant model. And perhaps if the economies of scale are optimized at 15 doctors, we'd have a beautifully competitive market of 15 doc practices. But the motivation to merge and acquire in order to possess market power is powerful, is sort of urge to merge, and we've seen that play out in the hospital market, and that's why I sort of pointed out that going forward, perhaps we really need renewed emphasis or more antitrust resources to try to prevent the sort of hospital market structure that we're seeing more and more, because it wouldn't be the worst thing in the world to have 20 vertically integrated competing systems in a market. and they could not negotiate, substantially higher prices or budgets. But to have two in a market is a problem. So there's no question that regardless of the source of the integration, it's been going on. It will continue to go on probably. I'm a little skeptical that payment reform is really going to drive it in a substantially new direction. But we need to start thinking about more aggressively policing the hospital market, putting in place policies that remove barriers to entry to make markets competitive, to support the sort of cooperative arrangements that don't involve ownership, to try to keep the markets as competitive as possible, regardless of the payment models. The payment models will help because to the extent that they will foster the most efficient model, then that's good.
Yeah, somebody who I can't identify right now coined the phrase cooperation. And I think that's what we need to have. I mean, pure competition won't work. The market structure won't support it. And consolidation doesn't work because that's the other extreme. But there needs to be some balance between the desire to do the best you can because you need to beat some benchmark or beat some competitor, and the availability of the services you need to be more efficient on a community-wide level.
Carmen?
Yes, we've got a webinar question from Brennan Spiegel. The question is, the evidence is compelling that vertical integration increases costs, but we still do not know with certainty whether it improves quality. Are you aware of high-quality research studies that examine the impact specifically on quality?
There isn't a lot of research on the quality front, is the bottom line. The one study that I mentioned in my presentation, which I believe was by Baker, did find that hospital employment of physicians is associated with patients ending up receiving inpatient care at lower quality hospitals. Now, you might consider a whole host of broader sets of quality measures that you might want to look at instead, but it's clearly a fruitful topic for us researchers to look into.
We examined this in the Medicare population a couple of years ago, and just a cross-sectional comparison of patients served by practices that were financially integrated with hospitals versus independent practices. And apart from the price effects we see on the commercial side, we found much higher risk-adjusted Medicare spending on the hospital side, in part because of facility fees, but in part because of more utilization. And very limited quality measures that you can construct from claims, but there were no evidence of better quality in the vertically integrated setting. It's a fair point, though, that our quality measures are pretty lousy, and it may be that the higher prices are worth it if in some other unmeasured dimensions of quality the care is better. But the prices are so much higher that you would think that it would show up even in our lousy quality measures like risk-adjusted mortality or readmissions. You'd think there'd be just a shadow of the benefit, but there doesn't seem to be.
Well, we hope you've enjoyed today's presentation and discussion, and I'd like to thank our speakers for their participation today. And before we give them a round of applause, I just want to remind you that the comment card in your packets or on the electronic survey offered to the webinar audience would be greatly appreciated if you could fill that out. But I'd like to thank our wonderful panel. And thank you to the folks who got us rolling, Carmen and Derek.